I'm not that good.
So hello, everybody. So the next two sessions will be broken up by a little coffee break. And we are going to be basically talking in depth about some complicated cases of sort of OUD and chronic pain overlaps. So just as a reminder, my name is Josh St. Louis. My pronouns are he, him. I work up at Greater Lawrence Family Health Center and also a couple of other jobs around the state as well. I am on the MASAM board of directors this year and was very lucky to be in charge of a chronic pain task force, which just concluded. And so we are going to be reviewing some of the information we got from the task force a little bit later, but you will sort of hear the themes of it throughout our discussion today. So I'm going to go around and we're going to introduce our specialty panelists. Marielle, do you want to start?
Can you hear me? Yeah. I'm Marielle Baldwin. I'm a family medicine addiction specialist at Boston Medical Center, and I'm the co-medical director for the START Clinic, the Stimulant Treatment and Recovery Team. We care for people who use cocaine and methamphetamine.
Hi, I'm Natalie Stahl. I'm from Greater Lawrence Family Health Center as well. I'm addiction and family med, and I split my time between the inpatient consult service and working for the Healthcare for the Homeless, doing a mix of primary care and addiction medicine.
Hi, I'm Sofia Matta. I'm the Senior Director of Medical Services at Home Base, which is a center for active duty special operations forces and veterans. And my background is in psychiatry, consult psychiatry, addiction medicine, brain injury medicine, and I'm an acupuncturist as well. And I also take call at MGH as well.
You hear me? Okay. Hi, everyone. My name. I'm back. I am a clinical pharmacist at Greater Lawrence Family Health Center. I'm very excited to be here and very excited to be on a panel with such amazing people. Primarily what I do is more behind the scenes, a lot of med access, a lot of PAs, a lot of chart reviews. Yeah.
Awesome. All righty. So we are going to get started, and we have generally similar bias disclosure to what I stated previously, and both of the cases we're going to talk about today are very much real cases. They've been a little bit abbreviated just for clarity. The other disclosure that I have is that I had a really grand plan of using Slido, and then Slido was not installed on this computer, so we will have a backup plan when the Slido slides appear, but we will try to keep it very interactive. So today we're really going to focus on the idea of nuanced decision-making around people with substance use disorders and chronic pain. So case number one, we have a 46-year-old man. He has a past medical history of type 2 diabetes. His last A1C was 6.7 on metformin. He has CKD3A, hypertension. He has HIV that's well controlled. His last viral load was undetectable on TAF-FTC bictegravir. He had a normal CD4 count. He has GERD. He has OSA on CPAP. He has a history of pulmonary tuberculosis that was treated in 2012 when he was diagnosed with HIV. And he also has OUD on buprenorphine naloxone, 8 milligrams BID. And he is here today actually for a follow-up visit in your primary care clinic. His OUD has been in remission since 2014. Prior to that, he used oxycodone and then progressed to IV fentanyl use. I actually should correct myself, really. At that time, it was mostly probably heroin with just a smidge of fentanyl. And he was hospitalized last week, 5 days ago, after a forklift dropped a large pallet on his left leg, which led to a complex open tib-fib fracture that was treated with debridement, intermedullary rod placement, and tibia and plate fixation of the fibula. He was discharged with a pain plan of acetaminophen, ibuprofen, 3 times daily gabapentin, and tramadol 25 milligrams for breakthrough pain. Real cases, y'all, real cases. I'm not making this up. And today at his follow-up visit, he states that his pain is somewhat unsurprisingly uncontrolled. And he is wondering whether or not you think he should stop his buprenorphine at this point. So everyone has feelings. So Please go ahead and turn to your seatmate and take the next 60 seconds to talk about how you might approach this case.
Us? Oh, gosh. Well,
You were like, wait a minute. I realize now that with these cases, the hardest thing is going to get people to stop talking. This is great. All right, wrap up your final thoughts. I'm just going to keep talking at you until you stop. Isn't it terrible?
Josh, can I just add?
Yeah. Ooh, Sofia has a comment.
I just want to add a comment from the inpatient consult service from a psychiatry standpoint. This type of person, I would constantly get the call for some behaviors or difficulty with the patient and the interaction with the team. And so often you can tell they're in severe pain and it's not being recognized or treated appropriately in the hospital. So forget about when they get home, but oftentimes it's really me ending up advocating for them to actually have proper pain management while they're in the hospital.
It's just wild for me to consider. Oh my God, a cowbell. Thank you, Heidi. This is really great. Okay, so what we do here, right? Obviously, this is a real case, but a very challenging case. And I think one of the things I want everybody to sort of take away from this is sort of thinking about a framework, right? So like, what are our concerns in this patient's case, right? Like, this patient had a severe acute painful episode, which is not being adequately treated. This patient has a history of OUD that's at risk of relapse, right? Are there data, right? Which we'll try to address a little bit. Or is it all theoretical? Are our concerns theoretical, right? It's all what we would like to call like vibes-based medicine, right? Like that's not a great way of practice. Would treatment with opioids be preferred in patients who did not have OUD, right? So if you removed this patient's OUD history entirely, would anyone have a problem giving this person full agonists? Oh, a forklift fell on his leg. It's ridiculous, right? This is like I've seen pictures of what the leg looked like. It was horrible, right? And so I think, and again, right, the patient does have OUD, so that's not a fully accurate thought experiment. You do have to ask yourself, right? Like if this person didn't have a use disorder, would my approach be dramatically different? And if so, why, right? How do we discuss safety with our patients, right? If we are going to move forward and give this person full agonists, how do we discuss that with the patient? Like, what is our relationship like with the patient? What has our communication been? Is it that we're consulting psych because of their bad behaviors, right? That's not a great relationship in which to be able to really frankly express your concerns about safety, right? And what is our role in balancing the patient's goals and also that question of safety, right? Like we have our tenets of medical ethics, right? Autonomy always reigns supreme, but it's not the only one, right? There are 3 others that we have to care quite a bit about. So panelists, what do you do? Marielle, what do you do?
Give them opioids. Don't stop the bupe. So Yeah, I mean, I think Mia brought up a really great point last talk in saying that I have found anecdotally, at least, that most of my patients who have a history of opioid use disorder, especially those who've been in long-term remission or remission for some period of time, actually don't usually want or are fearful of opioids for pain control. And I've had to have the conversations with them to say, I would recommend an opioid pain medicine in this case. And so I think the conversations with patients who have a stable OUD may look a little different than patients who don't or who are maybe in active use. I will also say just one thing that I think it can be, patients are often fearful and may want to ask for an opioid, but feel nervous about doing that because people label them as med seeking, which is a terrible term, and I hope no one uses that. And so I think it's helpful when I've had conversations with patients to say, to talk about the risks and benefits, and also to say, I would recommend an opioid in this situation. Like validate that is medically indicated or clinically indicated medication for them. You are supporting that. I think that goes a long way to kind of maintaining trust and rapport that hopefully you already have with the patient. But I think may be helpful in certain situations where a patient might be fearful of accepting an opioid, for instance.
Natalie.
I think something that I always want to, when people bring up the concern about co-prescribing, that I think gets lost sometimes is like they're on buprenorphine, and buprenorphine affects their mu receptors and how they, like how the oxycodone is going to feel to them, and I think that that's something that I like. It is just like pulling up the point that it's not just bad practice to take people off bupe because they'll have to get back on it later. Because I feel like sometimes it's like that's the argument for not taking people off bupe. But the argument for not taking people off bupe is also saying that it's far safer, right, from a like OUD perspective, for them to be taking full agonists on top of bupe than it is for them to be taking full agonists with no bupe. And either way, you're going to have like their tolerance to reckon with. I think I would want to know what their preference was. I'd want to know because some people are going to feel differently than others. And I had to write it down because I didn't want to just say the brand name, but like I haven't tried it yet personally. Suzatrigine, that's like the new sodium channel, I don't remember exactly how it works.
It's like non-opioid pain medicine.
I think their thing, if someone felt super strongly, he has CKD, you're not going to NSAID him. If someone felt very strongly that they were absolutely against being on opioids, then I would say let's have a like really short trial of maybe this, if that's what they wanted. But I would say, but I think with the caveat of saying the standard of care here is for your pain to be treated.
So sodium voltage gated.
I think also what I would point out is we have someone who clearly is taking care of himself by taking his HIV meds. He's getting treatment for diabetes. There's clear evidence in multiple areas of his life that he's trying to take care of himself and do well. And he's on Suboxone and has been doing overall, as far as we know, doing well before this event that happened. And looking at other domains are really important, just to say that this is not just an isolated OUD by itself. He's shown evidence that he's taking care of himself in many aspects of his life. And you can imagine if they have support systems, if they're involved, they've had these discussions like, oh my gosh, what am I going to do about this? And if you think of, going on this, there may be fear of relapse like the other folks have said up here, but also there may be concern that, not just about the relapse, what if I have that pull to want to use more and not wanting to have like a, 30-day supply of meds. And so have they had these conversations like, would it be easier if you had like 1 week at a time? I had a patient who had an ankle injury and had a fear of using the pain medications that he'd been prescribed. And he took all of them and threw them in the toilet and flushed them because he was so afraid that he was going to relapse. And it was clear, like, it wasn't that he was using it. He like told the doctor the next day, and they, rather than giving them the OxyContin, they gave him the oxycodone ER. And he's like, I want like a smaller amount that I feel like I control, and have someone else involved in knowing what it is in terms of like safety. for themselves, because I think the fear can be even that crippling that they're worried about it, but they do want the pain relief as well.
Casey, as a pharmacist, I guess my sort of two questions for you are, what is your reaction if you're the pharmacist filling the prescription? And also, what are your thoughts as the pharmacist so often helping to get things approved? Like, is this a situation that would be challenging or?
So for me, I think I'm in a very different place than, say, your very stereotypical retail pharmacist, with the, exposure that I've had with all the opportunities that I've had to work with such amazing providers. And I also read all of your notes that have all of these things documented. So it makes me feel a lot better. So I feel more comfortable advocating for your patients, for our patients, and, going to bat with the insurance companies, however long, 3+ hour appeals it takes, whatever it may be. But my first question on this was, how did they get tramadol 25 milligram tabs? Because that's not covered. So we'll start there. But no,
Slides were not written by a pharmacist. That's
obviously. No, I'm kidding. I'm kidding. But no, aside from that, thinking from a retail perspective, say I am a pharmacist that works at a chain pharmacy, doesn't have access to the EMR like I do. My first thought when I see the prescription come through for an opioid is not to say no. I'm going to fill their buprenorphine script first. Absolutely. Make sure that's ready for them. Not withholding that. But my next thing is, if the patient comes in before I have a chance to speak with the provider, ask them what's going on, what happened. This guy's going to come in and he's going to have like a trillion casts on because he has broken legs. But regardless, just reaching out to the provider, being proactive about it, not waiting for the patient to come in and just saying, oh, that doesn't make sense. Because truthfully, it does make sense. At the end of the day, as a pharmacist, I'm the last line of defense, if you will, for patients, before they get a prescription that may or may not harm them. So it's important for me, what I'm thinking of. Yes, I'm obviously thinking of my license and my loans and all of that I will not be able to pay off if I'm not a pharmacist anymore. But also, I'm really thinking about, the patient, and is this a good plan? Is this a safe plan for the patient? In my current role, the things that I'm thinking of is, what are the patient's goals? What are the boundaries that the provider has set? What kind of safety guards were talked about? If this patient 10+ years in remission, so, we're probably not as concerned. But, having a lockbox, having, discussions about safety at home, prescribing naloxone, those are things that I'm looking at. And those are things that you most definitely are going to want to have documented in your office note when I send it for the PA.
My memory is we don't need a PA always for the first prescription, but that when you renew the prescription, if you have co-prescribing,
Yes.
and they tend to get approved.
Yes, usually it's the first 7, well, for Mass Health, it's 7 days. For some insurances, it's the first 10 days. You can fill that first, initial supply of having, something like bup plus an opioid together. It's really those subsequent fills where it becomes an issue. So on the plus side, if they're leaving the hospital, they'll get some sort of medication for that acute pain, but it's really important that we have a plan before they run out and they come to you and they're in pain.
Isn't this the greatest panel, y'all? Can I just get like an extra one? So great. All right, so we're gonna move on through our case. So we're actually gonna fast forward a year. So you actually agreed with the patient at the time that he had just like bashed up his leg and opioids were appropriate. And so You prescribed oxycodone 20 milligrams 3 times a day as a PRN, and you tapered him pretty closely. He was really worried about return to use, expressed that to you, really wanted to follow up closely and wanted lots of touch points because he was worried about losing control over the situation. And so he tapered essentially over the 4 weeks after the surgery. He continued to have pain over the next year. He completed multiple rounds of physical therapy. He wasn't able to stop using a cane because of discomfort. And orthopedics actually eventually diagnosed non-union of the fracture, and they're now recommending a return to the OR for another procedure. He's really had no other major changes to any of his other medical problems. He's really fearful of his pain, given what happened last time, right? He wasn't super happy about the last situation. And orthopedics also wasn't super happy about how it went and really wants to take good care of this patient and wants to work more closely with you this time in preparing for a surgery. And so currently for pain, he's taking a whole bunch of stuff you have recommended to him, which are helpful and that he hopes to continue. So turn to your seatmates and think about what might you recommend to this patient. Yeah. Yeah, he's still on mute. Yeah, absolutely. You've never stopped. Really very important key question. So what might you recommend? Take 60 seconds. What do you do with this guy? He might have surgery. How do you prepare him for surgery? Alrighty, everybody. So the patient's going back to the OR. How do we approach this situation? Hey, it was so much faster this time. Huh?
How about,
That's
we
okay,
need more
bring it.
time.
What is Natalie saying? All right, so our patient is going to go back to the OR and is going to need another surgery. So panelists, anybody, how do you approach this situation? How do you support this patient?
I think this is a really good, given now this is going to be an elective procedure as opposed to the first one, which is more emergent. This is a really good opportunity to partner with your surgeons. Natalie and I were just talking about how hard that can be depending on what setting you work in. I'm at Boston Medical Center. The patients who I'm, presumably most patients are seeing the surgeons at BMC. We have the same record. We can communicate easily. I realize it's not always like that. And some people are seeing a surgeon in the community and maybe a little bit more challenging. But I've never had pushback from surgeons when I've reached out to them proactively. And I've almost always had an expression of appreciation for like partnering on a perioperative pain plan. So my question usually first for the surgeon or surgical team is, in a situation like this, what is the typical pain? What are the typical pain needs of a patient undergoing this type of intervention? This is a little different because it's a revision surgery, but typically what do you see in a patient who doesn't have opioid use disorder, right? Just give me a baseline. And also, please don't stop their buprenorphine. And then together kind of making a plan to, follow the patient closely, check in or have somebody, a colleague check in around the time of the operation, and then perioperatively have a quick follow-up back into outpatient clinic. So I think really try and as best you can in your specific setting to partner and talk with the surgeon ahead of time and make a plan can be really helpful. Presumably in this case, likely going to need opioid pain medications. And so also talking with the patient about what his goals are, what his expectations for his pain are, making sure that I think setting pain expectations can be really important. Like, is your expectation, he's had pain now for a year. Is his expectation post-op that his pain will remain at a 4 out of 10 as it is now, or go back to that? Or is it that he wants lower pain? Like, what is his goal, and kind of adjusting what might be realistic in terms of expectations, I think can be really helpful and kind of setting the stage.
Other thoughts?
I think from the community perspective, because it is hard sometimes, like when you're not in an academic medical center where you have like easy communication tools. Like I often write, I think I write a letter like with my cell phone number and my information, and I will give it to the patient so they can give it to their surgeon. And I think signing releases, because we don't always remember, it's hard to get that. It's that one really important thing that you need to do when they're there. And then I think maybe asking pharmacy if there's anything to do ahead of time. Is there anything you can do ahead of time?
Yeah, I mean, the biggest thing that we've already kind of touched upon is just communication, like proactive communication. Don't wait until it's 5:30 on a Friday to, make these phone calls, try to make them a little bit more proactively. I know that everyone's schedule is a little bit challenging for sure. But it's not going to be any easier, later in the day. But really just communication for me, it's obviously much easier with the organization that I work with, the pharmacy. I have a very good relationship with the Greater Lawrence pharmacies because it's just easier to communicate, but I do have relationships with other pharmacists within the community as well. Some good, some not so good, but that's okay. But just, I've never had a pharmacist, even me, like me being a pharmacist in the clinic, talking to a pharmacist in the retail setting, I've never had a pharmacist be mad that I called them and said, hey, we have this patient, here's the story, you're going to get this prescription, it's going to have all these notes on it, I'm going to wait on the phone while you receive the prescription to make sure, like, if you have questions, I'm willing to answer all of your questions ahead of time. Here's the plan. And they're just very grateful for that because it gives them a sense of comfort and confidence when they're checking that prescription because they know that there's thought behind these prescriptions. A pharmacist can't assume what is happening, or they don't want to assume that you've done all of the things, right? They would like to, but at the end of the day, they can't assume that because of just history. So.
I would echo what Cassie said about being proactive. That's extremely important in developing a plan. I will talk about the consult side. On the inpatient side, the orthopedic surgeons are definitely interested in hearing from psychiatry and how to manage acutely after a surgery. So they do tend to involve us at that point. Oftentimes, I like to ask or make sure that they realize the surgeons may stop the serotonergic medications before surgery, and duloxetine can have a really nasty withdrawal. So I would just make sure that you're proactive about talking about this. They may feel worse. Make sure that once you can restart it, that you restart the duloxetine because that might cause a problem. But also they're going to look at it and there's all of these medicines. And so giving them a heads up about them and saying, okay, well, you can hold this while they're like immediately post-op or whatever, and this might not cause a problem, but just realize that this might. And also predicting that for your patient that they might do that so that they're not in agony having like, their whole entire visual field is moving or they're getting these like zaps or headaches and stuff like that, because that can be uncomfortable in addition to the acute post-op pain.
All right, so it's time for surgery. You are in agreement. So the patient actually undergoes an extensive orthopedic surgery lasting almost 6 hours. Per orthopedics, he is likely to have a chronic leg length discrepancy now and might need further revision at a tertiary care center. And I quote this orthopedic surgeon, "That was the hardest surgery I have ever done in my life." He was initially managed in the hospital actually with a PCA. at your urging, given all that had happened. And then once he was ready to switch to oral pain medicines, you went back to the regimen you had used before, this oxycodone 20 milligrams 3 times a day, in addition to his other medicines, which were continued. You actually changed his buprenorphine to TID dosing during the hospital stay to see if you could maybe get a smidge of added pain benefit out of that. And he was on board with that. And so now you're at the hospital follow-up a week later, and he reports that his pain is tolerable. It's a 4 out of the 10 most of the day. It is sometimes worse at night, but now he's really reporting new and worsening cravings for opioids, and he's really, really fearful about return to use. And he really hopes that you will actually just taper this oxycodone off really quickly, despite all that happened, just because he's so fearful of his return to use. So to my panelists, how do we sort of manage this when patients are in this situation and they report, you know, on the one hand, he's had this really extensive orthopedic revision surgery, right? And he's in the immediate post-op period, but he is like, I just don't think we can keep doing this. Like, I'm too afraid that I'm going to return to use.
I think it's tricky. But you know, having a really open and frank conversation with the patient about their concerns, about your concerns. I think in this particular case, I might express that a concern I have is, you know, wanting, of course, to treat the pain and also respect the fear that he has with the cravings. And the concern I would have with a quick taper off the opioids in the setting of cravings and how that might put him at higher risk for overdose, for return to use overdose stuff. And so, you know, expressing those concerns, hearing from him, and then, you know, considering something like, you know, we generally historically have said 24 milligrams a day is, you know, max or has the ceiling effect for OUD, but we don't have, you know, a ton of great evidence. And although there haven't been RCTs for giving doses above 24 milligrams, there are some observational studies. And I think anecdotally, probably some of us have seen that patients can benefit from more than 24 milligrams. And so in this particular case, one suggestion that I might have would be considering staying on the opioid pain medicines and adding some additional buprenorphine to treat the cravings, because it sounds like his pain is controlled. So not really wanting to mess with that too much, but just figuring out a way to treat the cravings for opioids.
Does anyone have a timeline of how you would taper this person? Everybody inhaled.
I think I have concerns about tapering, just like what was already said. I think also, I'm going to put on a hat. I mostly don't prescribe medications at all, and I do acupuncture. So I would like to recommend that we think of alternative treatments. And you may think it's a laugh, but I've treated people with spinal cord injuries who've had a pain level of 8 and have walked out of my office with a pain level of 2. So do not underestimate the power of integrative medicine for someone who has and also for cravings as well too. As you know, the NADA protocol, I treat people for pain, stress, sleep, and for cravings and daily get remarkable responses.
I think if he was able to taper in 4 weeks last time, that seems like a pretty great, I mean, that seems like what most people would be optimistic in a lot of these surgeries, and you can aim for that. I echo, I think the more view that I was looking up there's this paper which Stephen Markman on evidence on buprenorphine dose limits, a review. It's an amazing paper. So, and and Mass Health covers it. I think maybe chronically, sometimes after a few months we get a prior auth, but they stopped that. Okay.
It still may come up as a rejection at the pharmacy. You can get it to go through. I make some calls, we fix it. But yes,
we'll fix it for you.
it's not need a PA.
You can't do it that day with a lot of Medicare things, but you could do it that day. And I think the other option is a long-acting buprenorphine, because that might also give them a sense of comfort, and B, take away some of the stressors about like the timing and
That's a great idea.
Yeah, absolutely. I mean, I Also, I don't have a CDTM, so I don't prescribe. I also am kind of ironically a fan of like de-prescribing. But in this case, for this patient, you know, there are red flags. He's already expressing that he's having these cravings, and, you know, we want to make sure that we are keeping him safe. And, you know, it's all about the discussion that you have with the patient and expectations and understanding that, you know, yes, I hear you when you say that you want to taper off of this opioid, you know, as fast as you can. However, your pain is well controlled right now. And if we taper this off, it most likely will lead to increased cravings and all of that kind of stuff. So you really want to make sure that, you know, you're having that kind of extra discussion to make sure. And then definitely, I'm always a huge fan of including any sort of like non-pharm, non-opioid kind of options for pain management as well, because I think one of the problems with not having all this kind of robust data and, you know, RCTs and all of that, part of the issue is that pain for everyone is different. And, you know, my 10 out of 10 is maybe not the same as anyone else's on this, you know, panel here. And then not only that, dosing differs based on the patient as well. So I think that's probably one of the main challenges why we haven't had any of these trials, because how do you standardize that regimen, right?
I think the one last thing, just in case this wasn't clear. So I think, you know, expressing concerns, trying to see if, you know, another plan, another option other than a quick taper can be achieved. And at the same time, if the patient is, if that's really what they want to do, then coming up with a taper plan together with them, maybe one that's less quick.
All right, we're gonna zoom. We've got just a few minutes left in this case. What happens after the surgery? So the patient actually misses 2 appointments, doesn't answer the phone, is pretty MIA for about a month. Does continue picking up his other medicines via his pharmacy refill history. And then he actually returns to care about 8 weeks later and reports that he actually did relapse due to uncontrolled pain and opioid cravings. He stopped his bupe. He was taking oxycodone from his wife, who has a prescription from one of your colleagues, who's may be sitting in this audience right now. But then needed more and was buying from the street. And then he actually had an OD that required Narcan in the emergency room because it probably was pressed fentanyl pills that he was using. He tried to restart bupe on his own, and it did not work, unsurprisingly. And so he actually admitted himself to the local OTP and got on methadone and was on about 75 milligrams and had discontinued use. So a lot has happened in 8 weeks, right? I was like, this is like a 15-minute visit. I was like, whoa. But he's still having a lot of pain, right? And he's really struggling because he's got to go to the OTP every day now. And so I'm going to continue ahead in our case for us. And so he actually ends up tapering his methadone because he really wants to get back to bupe. He found methadone really helpful, but actually just stayed on a 6-month program with the OTP where he was going to be up and then down. And he actually did a low dose bupe overlapping taper, in part because he was going to a great OTP that was really communicative with us. And so he actually managed to get back on bupe, albeit at a higher dose. Previously, he was on a total daily dose of 16. Now he's on 24. And he's not had any use during that period. So now it's been sort of 6 months since that episode of relapse. He's continued on all of his other pain medicines, right? He does find them to be really helpful. He's doing all the things. He's doing PT. He's tried acupuncture. He loves it. He's going to it. He actually has made some work in his other medical issues. So he actually transitioned from Biktarvy to long-acting injectable Cabenuva for his HIV for convenience. He's really excited. He's maintained viral suppression during that period. He's like doing all the things, right? And here today he says that he's starting to get more pain as the winter's starting. And he wants to know if you would prescribe an RX for oxycodone for him to have for breakthrough pain on very cold days. So panelists, will you prescribe him oxycodone?
How many does he want?
How many is too many, Natalie? 5, 10, 100?
There's a lot of things that I'm willing to prescribe 1 or 2 a week. And I think that for the pure purpose of listening, like benzos, I hate chronic benzos as a rule, and I think, I think this also gets exposed to pharmacy a little bit, but I think there's a lot of value in saying if the worst 2 moments a week, you can take something and the psychological benefit of that. But I think that line of how much and are you going to decide that from the onset is really hard.
If I can just add, the question is, well, what happens on those cold days? Because if you think of the crush injury, is there a neuropathic type of pain? Because as we know, opioids don't necessarily address neuropathic type pain better than other types of treatments. So I would want to know more about what the pain quality is and how it's impacting him before I say yes to that. It's not a no, but it's like, I think I want to know more.
Yeah, absolutely. Just having more information from him, and really, like, how many times a week do you feel that you may be experiencing this pain? What is something that we can talk about? I'm a huge fan of like shorter periods of time, either between visits, whether it's an in-person or telehealth, whatever it may be, or just shorter scripts. Yes, it makes more work for me because I have to call pharmacies and insurances for DUR overrides, and it's a glorious time. But it doesn't need a PA if it doesn't, whichever. But I'd much rather do that and know that there's some sort of plan. You're checking in, you're saying, okay, well, how is this going? Instead of saying, all right, here's 20 pills for the month. Good luck. Let me know how it goes.
And so say a provider, Casey, we're asking you like, okay, we've done all those things. The patient sort of understands his risk. He understands what's happened. He wants to do weekly telehealth check-ins for his own safety. He wants short prescriptions only. What can I prescribe that's going to go through?
Nothing.
Like, is there a way? Like, how can I do it?
So one of the things that you can most definitely consider if the patient is open to it would be transitioning to injectable buprenorphine. It's kind of like a little roundabout, if you will, to circumvent the insurance, because one is typically on the medical side and one is in the pharmacy benefit side, although ironically with Mass Health, Sublocade is technically pharmacy benefits now, but we're just going to leave it how it is. If anyone works for Mass Health here, please don't listen to this. But I mean, that's definitely an option. And then that way you really are circumventing the need for any PAs, any prior auths, if you are prescribing just like a short course of opioids.
Thoughts from others on what to do?
Yeah.
More buprenorphine. Yeah, right. Could you just increase him to a higher dose of buprenorphine? Right. Yep. Okay, 1 minute remaining. So we're going to get to the end of the case. I think the biggest thing to remember, right, it's all about balance, right? Like we're balancing a lot here, right? Opioids certainly have risks, as we showed with this patient, right? It led to a fair amount of harm for him to return to using full agonists, but it also had significant benefit, right? And so how do we sort of manage this? I think in the end, it's really customizable. So you actually agree with him, and he wants to come in, he wants to be seen more often, all of that stuff. He is doing pretty well. He's taking maybe 1 dose 1 or 2 times weekly. He does drug testing. It all looks great. He's going to get a new ortho surgery, and pharmacy says that this can't be continued. And so what do you do? I'm going to skip the panelist thoughts. So Casey and I did a big prior auth. We wrote all the things. You do a peer-to-peer, which is declined. And so I use my MMS connections to schedule a personal meeting with the director of Mass Health Pharmacy, who said to me, I will never approve this request as long as I work here.
Yep.
And so he says he is fine just taking 1 or 2 tablets of oxycodone from his